because I don't want any disturbance in between. Yeah, please.
Yeah, ma'am. So we are starting.
This
So very good
meeting is
evening, doctor.
being live stream. Yeah,
Yeah, ma'am.
you want it to me, got it?
Yes, ma'am.
Shall I press it?
Yes, ma'am.
Okay.
So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is recent advances in in-vitro fertilization. I welcome all the audience and I request them to post their queries, if any, in the chat box so that we can have a Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. M.L. Amani, ma'am. Madam has done her MD Gynec and Madam has her fellow in infertility. Madam is currently the senior consultant at Raja Hospital, Yusuf Kuda, Hyderabad. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings.
Thank you, Mr. Stalin. Good evening. Yeah, today's topic is recent advances in IVF. Next slide, please. Next slide, please. Yeah. Hello?
Yes, ma'am.
Yeah. You able to hear me,
Yeah,
Mr.
ma'am.
Stalin?
Yeah,
Yeah.
ma'am.
Okay. So, what is IVF? Assisted reproductive technology, ART. In vitro fertilization literally means fertilization in a glass, giving us the familiar term test tube baby. During the IVF process, eggs are removed from the ovaries. They're fertilized with the sperm in the laboratory in a petri dish, and the fertilized egg, the embryo, is placed in the woman's womb. This is called assistive reproductive technique or IVF. Next slide, please. IVF history. Uh, interesting topics. If we know that we go back into our ancient history, you hear that, Duryodhan was born through IVF. In vitro fertilization is a fertility procedure which first succeeded as recently as 1978 by Dr. Edwards. He's an embryologist, and Dr. Steptoe, a gynecologist in England. Since then, the technology has been further refined and developed by physicians and embryologists with over 20,000 babies born worldwide. This is a short history of IVF. Next slide, please. IVF is used to overcome female infertility in women due to the problems in the fallopian tube, blocks, not working fallopian tubes, etc. It may also assist male infertility, that is azoospermia, asthenozoospermia cases, where there's defect in the sperms, where there is no sperms, right? Where there is absence tail of the sperm. And in this case, we go for ICSI or IMSI. ICSI may be used where a sperm cell is injected directly into the egg cell with the help of a laser needle. This is used when the sperm has difficulty penetrating the egg. And in these cases, the partners or a donor sperm may also be used. ICSI is also used where the sperm numbers are very low, that is oligoasthenozoospermia. Next slide, please. So, what are the reasons or where do we approach the help of IVF or ART techniques, right? So, female and male, okay? Female, when the tubes are blocked or damaged, and very rarely unexplained infertility cases where nothing works. Next, male, the lining of the womb is affected. This is not so. The male infertility, the sperms do not swim well, the sperm number is very few, the ovaries do not produce eggs, the quality of the eggs is compromised. Next slide, please. So basically, the factors where we go for IVF are the male, female, and the tubal factor. The tubal factor would be the first, of course. Next, male. If the sperms do not have the capacity to swim, that is oligospermia, asthenospermia, zoospermia, azoospermia. The females, when the age factor comes into the picture, the follicles are not good, endometrium is defective, or sometimes the embryos are not formed good. There are the ways when we go for recurrent pregnancy losses. These are the indications where we go for IVF or ART techniques. Now, the basic thing what we do in an IVF, we stimulate the patient with hormones to increase the ovum or harvest the ovum, right? In a female, we get mature ova and then collect the semen from the male, and the sperms are in there are two methods, that is IVF, ICSI, and IMSI basically. IVF, in a petri dish, we space the sperm and the ova, mature ova, side by side and leave it in an incubator for 2 to 3 days and see the formation. After 2 days, we watch for the formation of the embryo. In an in an ICSI technique, we use with the use of a laser needle, we inject the sperm inside the mature ova in a test tube, right? And then place the petri dish in an incubator for 2 days for the development of the embryo. After the formation of a good embryo, we transfer the embryo, the blastocyst, day 3, day 5, in the womb of the mother, in the endometrium, right? Next slide, please. Milestones in reproductive medicine. 1960, this is a recent development. It started from basically 1950s, 1960s. 1960, ovarian stimulation with CC and gonadotrophins. 1970, secretin synthesis mechanism of GnRH and gonadotrophins and in-vitro fertilization. 1980 was a decade where much improvement has come over with the discovery of agonists and antagonists. So GnRH agonists and gonadotrophins and cryopreservation. This was a breakthrough. 1990, recombinant gonadotrophins, pre-implantation genetic diagnosis, PGTP, then ICSI, GnRH antagonists, and 2000 was IVF maturation of the oocytes, embryo stem cells, single embryo transfer, vitrification. Next slide, please. Modifications in the IVF or ICSI cycle. Every year, we are seeing a lot of modifications in the IVF. So we need more than one egg in a cycle. Previously, in 1980s, we used to concentrate only on one egg or so. Now our aim is to get minimum 5 to 6 eggs with no damage to the patient, or I may say OHSs. Not all fertilize or grow. Not all embryos are good. We want to transfer 1 to 3 embryos for a good success rate. We do not want the gland in the brain to become confused in treatment. Next slide, please. Success rate of IVF varies from program to program. It is dependent on the correct diagnosis of the patient and age. Pregnancy rates vary from 25% to 30% per oocyte retrieval. The take home is about 15% per procedure, maybe less, 10% we can say. Next slide, please. So coming to the history of ovarian stimulation, in 1970s, we used to have Clomed, HMG. In 1980s, we started GnRH agonist, which is good. And then 1990, which is called the decade, we started getting recombinant FSH, antagonist, GnRH antagonist, HMG, or recombinant FSH. And 2000, we are in the long-acting FSH, still under evaluation. Next slide, please. Long-acting, FSH. This is a basic cycle. Like we start with the FSH or HMG and stimulate the patient from day 2 basically. And then we give, depending on the follicular size, we get the follicle size up to 14 mm. We start the agonist to prevent OHSS. And then on the day of the trigger, that is when the follicles are 17 to 80 and 18 mm, we give the trigger HCG, recombinant HCG, 1000 international units. And then once the for 24 hours are done and we have the hormone levels good, we go for the OM pickup and IVF, that is we IVF or ICSI depending on the sperm, and then embryo is formed and the best embryos, minimum 2, are transferred into the mother. Next slide, please. The first baby born by Kisspeptins in 2013 and Hammersmith Hospital, UK. London is actually the one who developed the IVF babies, first babies. Next slide, please. England. What are kisspeptins? Naturally occurring hormones, which is an important regulator of reproductive access, and it is safer as the chance of OHSS is reduced. Instead of HCG, kisspeptin is used as the trigger. Dosage is still under trial, 0.6 to 1.2 nano ml. Next slide, please. The mild stimulation protocols. Approach for IVF is aimed to develop more patient-friendly protocols in which the risks are minimized. I mean, the injections for the stimulation are minimized and the OHS is completely minimized. The risk of OHS is completely minimized. The result still same. A mild IVF cycle is defined as either as ICI-MMR association, stimulation regime in which gonadotrophins are administered at a lower than usual dose for a shorter duration throughout a cycle with a GnRH agonist is given as co-treatment. A stimulation with OCs are used either alone or in a combination of GnRH antagonists. Next slide, please. Male infertility. Male infertility is increasing since 2000. Percutaneous epididymo aspiration, which is called PESA, testicular epididymo sperm aspiration, TISA, microsurgical epididymo sperm aspiration, MISA, harvesting sperm from testicular tissue plus ICSI. Even in patients with Sertoli cell syndrome, scattered pockets of sperms exist. Even with FSH 3 times, sperms are found 30% of the cases. These are combinations with IVF. When there is azoospermia or asthenozoospermia, PISA, TISA, MISA plus ICSI is used, are giving good results. Next slide, please. Existing new development in male infertility. In non-obstructive azoospermia, though these men have no sperm in their semen, we can find sperms in the testicles. Is almost half of these cases by using operative microscope and going for TISA, MISA, PISA. Pregnancies are achieved in 1/3 of these men in whom the sperms can be found within the testicle. Next slide, please. ICSI plus micros TISA, 179 cycles of non-obstructive azoospermia, 22 cycles done, fertilization rate is 33.2%, 6 cycles chemical pregnancy, 3 cycles normal pregnancy with 3 healthy babies. Next slide, please. Before going to the advanced sperm preparation methods, now we are in PRP treatments where we install the plasma protein at totipotent cells into the testicles to get the increased number of sperms. Advanced sperm preparation methods. Morphological assessment by means of motile sperm organelle, morphological examination. Mosome is increasing nowadays. Electrical charge. This from the seminal plasma membrane, the zeta potential allows them to adhere to the surface of a positively charged tube. The resulting population has better quality with normal DNA and chromatin condensation. Molecular binding characteristics of the sperm cell. The two methods currently used as sperm binding to annexin B and hyaluronidase, actually, hyaluron. Raman microspectrometry and polarization microscopy are also in the offering right now. Next slide, please. Mesome, motile sperm organelle morphological examination. With mesome, the morphological status of the acrosome, post-acrosomal lamina, the neck, mitochondria, the flagellum, and the sperm nucleus is examined. For the later, the shape as well as the presence of zinc, size of the vacuoles is also observed. The combination of mesome and ICSI has been named intracytoplasmic morphologically selected sperm injection, that is IMSI, which has shown the increase in the fertilization rate and the blastocyst formation, implantation rates, and pregnancy rates. So the combination of morphological examination of the sperm and ICSI is called as IMSI. Next slide, please. So here we are seeing the slides of the sperms. So we are looking at the shape, content, normal nuclear shape, vacuole size, and the large vacuoles. Where you have C, you have large vacuoles. B is normal nuclear shape, normal vacuoles. A is normal nuclear shape and content. So we can work with A and B, not with C. Selection of the motile spermatozoa with normal nucleus, object to elimination of the sperms with vacuoles within the nucleus. This is called IMSI. Next slide, please. So intracytoplasmic sperm injection outcome versus intracytoplasmic morphologically selected sperm, ICSI versus IMSI. Let's see the slide. It is very interesting. Comparative study of 50 couples, right? IMSI. Female age less than 37, more than 3 retrieved metaphase 2 oocytes in the ICSI cycle, 2 failed ICSI cycles, right? So here IMSI we have 50, ICSI we have 50, equal. Fertilization rate, top quality embryo, implantation rate, pregnancy rate, miscarriage, okay? So comparative, again, 80 couples, we went there. Same factors, 37-year-old, less than 37, 2 previous failed ICSIs, and the same. Metaphase 2 oocyte is taken. Here in a small control study, 80 and 50, we have 80-80, equal rates of pregnancy, fertilization rate, embryo rate, etc. in IMSI and ICSI. Now let us go to the third study. This is randomized. That is 446 couples. At least 2 previous diagnoses of severe oligoasthenospermia. 3 years of primary fertility. That is, the age factor is there, less than 35 years, but they haven't randomly allocated to receive ICSI and IMSI treatments. Here we notice 227 have been positive with IMSI and 219 with ICSI. Next slide, please. So this is about the male infertility. Let's come to the female infertility. Now, how to select the best embryo? The fertilization rates depends on the embryo formation and selection, and definitely implantation. Next slide, please. The best available method for embryo selection is morphological evaluation. However, implantation rates in general do not exceed 35%, although varying results have been reported, 35 to 40. Hence, a strong drive for finding alternative selection methods. Next slide, please. Basically, we select the embryo depending on the 8-cell stage, regular, then the polar body, and perfect blastocyst formation, right? So now other factors to select the best embryo. Embryo quality biomarkers. These are invasive. The microscope selection is non-invasive. Now we are going to the better embryo quality biomarkers. This is done by invasive method. Rational, 50% in vitro produced embryos are abnormal. Developmental stage, the embryo biopsy is done. Polar body, blastocyst. Okay. Next, techniques. Fish techniques. We do the fish technique, PCR, the DNA amplification approach, basic approach, CCH, combination of molecular and cytogenetic technique, single nucleotide polymorphism microassay, next generation sequencing, single gene, quantitative real-time PCR. Next slide. Pre-implantation genetic screening, which is called PGS. So the once embryo is formed, we look into the microscope to see the regularity, the polar body, and the development of the cells. And now we are going into an era where we go for invasive techniques to tell us this embryo is the best. So that are the techniques we saw, the fish technique, the genetic screening and all. So now we have come to the pre-genetic implantation screening. That is the day 3 embryo developed from the fertilization of the ova and the sperm is analyzed, right, of by single fish or fluorescence in situ hybridization for aneuploidies for a limited number of chromosomes. That is, we study the chromosomes of the embryo to see that any aneuploidies are there, any deletions are there, any depletions are there. Is it a perfect embryo genetically, right? Next slide, please. This PGS we recommend for the patients who have failed IVFs, failed ICSIs, who have abortions after IVF, and recurrent pregnancy losses. So next, selection of the best embryo by CGH array. The pre-implantation genetic diagnosis with testing all the 23 pairs of chromosomes by a microarray technique, which allows the differentiate chromosomally normally from abnormal embryos. They replace only the normal ones on day 5, discarding the abnormal embryos. Next slide, please. Selection of single blastocysts from fresh transfer with array CGH and standard morphology alone for good IVF patients. Good prognosis for IVF patients. So we have aneuploidy rate is nil. Twins are nil. Ongoing pregnancy rate is gone up to 60%. Clinical pregnancy rate is 75%, which is very good. Next slide, please. Pre-implantation genetic diagnosis can also be utilized for translocation, single gene defects, BRCA1, BRCA2, and cystic fibrosis. Next slide, please. PGD. Non-invasive methods, omics. High technique non-invasive method to select the best embryo includes metabolic profiling, amino acid profiling, respiration rate measurement, and B refringing imaging. Next slide, please. Let's come to the first, metabolic profiling. Spectrometric tests are used to measure the metabolic changes in the culture medium of the embryos. Proteomic profiling, proteins produced by the embryo and released into the culture medium are identified. Amino acid profiling, amino acid depletion and production of by the embryo is assessed by using the culture medium. Next slide, please. Embryoscope. This is a new invention where we are using embryoscope nowadays. The novel monitoring system for continuous observation of the early embryo development around the hour was introduced by the Unison's Fertilization USA. In December, the world's first twins born by use of a new embryoscope at Cleveland Reproductive Center, Ohio, USA, 2011. Next slide, please. Time-lapse imaging. Now the incubator is hooked up with video system capturing thousands of images of the embryo using up to blastocyst. The normal embryo forms a blastocyst 6 hours earlier than an abnormal embryo. The embryo need not be disturbed as it's a conventional IVF. Better success rates are claimed. That is, in the incubator, the Petri dish is continuously photographed, and we see a series slides of blastocyst formation from a normal embryo. That's an embryoscope. Next slide, please. Human cloning. The first successful human cloning, Cell 2013, Shaurat Mitalipov et al. Cloning of human embryos for therapeutic purposes was made legal. Amendment to the Human Embryology Act 2001. Cloning human for reproductive purposes remain illegal still. Next slide, please. Fertility preservation in female cancer patients. That is oocyte freezing, embryo freezing, ovarian tissue cryopreservation, and ovarian transplantation. Next slide, please. Clinical 2000 onwards. First successful ovarian tissue transplant after frozen cell storage. Pregnancy after transplantation of the ovarian cortex. Retransplants. Ovarian transplant between two identical twin sisters. 2005. Sherman Sibler. Next slide, please. Next slide, please. This is ovarian transplantation. Ovarian tissue is cryopreserved before the cancer treatments or chemotherapy, and it is thawed and transplanted into the normal ovarian tissue. Next slide, please. Review of 60 cases, 24 live births reported till date, better freezing techniques, enhance the vascular blood before transplantation. Next slide, please. Uterine transplantation. Transplant done from a donor, hysterectomy done 99 days after due to the acute vascular thrombosis. Patient conceived with IVF, miscarried at 8 weeks. 9 successful transplants, Sweden. Live birth after uterine transplant remains challenging. It is too challenging. Next slide, please. Artificial uterus and pregnancy outside the baby, evolving era. We are not still there. Next slide, please. Limitation of IVF. We have to completely counsel the patients before we start an IVF. Genetic defects of the oocyte, genetic defect in fertilization of the sperm, fertilizing sperm, environmental mutagenesis, inadequate supply of the nutrients and hormones, exposure to toxic agents and free radicals. Next slide, please. The ART laboratory tomorrow. Morphological biomarkers, proteomic-based biomarkers, genetic-based biomarkers, metabolic-based biomarkers to get the best embryos and gametes. Next slide, please. That's where we are going. To conclude, the field of reproductive medicine, ART, is fast progressing. Aim of infertility treatment is to be simple, safe, successful, and less cost effective. In donor programs, surrogacy, same-sex reproduction, etc., there is a lot of political, legal, and ethical issues involved. Future looks like it's a well-lit tunnel, and we have a lot to explore yet. Next slide, please. Thank you.
Thank you, ma'am. Thank you very much for that wonderful presentation. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will read it for you.
Sure.
Ma'am, I have few queries, ma'am. Like, what will be the role of adjuvants, ma'am? Like, what called as leucine, arginine, myonestols in this IVF treatment?
They do wonders. Definitely, they do wonders. Because what we are dealing with micro deficiencies, like, your last slide. So all the micro deficiencies have to be replenished. All these adjuvants have to start 3 months before the IVF, we go to IVF. And definitely the success rate is increased.
Okay,
The
ma'am.
final outcome is we need a healthy baby.
Okay. Ma'am, when it comes to male factors, there are considerations like male DNA fragmentation. So, how much important to evaluate this DNA fragmentation for a successful pregnancy?
When we have two failed IMCs or ICSIs, and the male factor is the cause, then definitely DNA fragmentations comes into the play
Okay,
to
ma'am.
evaluate the sperms.
Okay, ma'am. So is that necessary to evaluate the male at the initial stage itself, or I can wait for one or two unsuccessful ICSIs or IUI?
No, see, depending on the case. If we have a case male oligoasthenozoospermia, where the chromosome, where we have clitical, and then the history basically. If they have a history of abortions or a deformed child in the family, right? Or and then we come to the male sperm analysis, semen analysis, showing asthenozoospermia, and stuff. Then it is better. I would recommend to go for the chromosomal analysis of the male partner and the female partner, and definitely DNA fragmentation, because there we minimize the amount they are spending, everything together. To get a the ultimate thing is we need a good embryo. You make them spend so much amount, and at the end of the embryo incubation period, oh, we are so sorry, your embryo is not good. That is not acceptable by the partners. So depending on the history of the family, history of the male partner, and if they have gone IVF, through IVF, so the history plays the role here basically. Family history, the male, if male is just mild oligospermia, I'm telling mild, then I won't advise them to go for DNA fragmentation, which is very expensive. But if the male fact, they have a family history and the male factor is oligoasthenozoospermia, and we have a clear cut male motility is very less, the morphology is bad, basic morphology is bad, I advise them definitely go for DNA fragmentation, because we'll be minimizing the factors of IVF, the cost, and also we'll be counseling the patients. And the chances of getting, I would even advise them to go for BGT also, PGT in such cases, including DNA fragmentation.
Fine, ma'am. Ma'am, we are in the again we are in the starting of third stage of third cycle of this COVID, ma'am. So is there any impact of this COVID-19 in male parameters or in female parameters in the last 2 years, ma'am? So how do they impact on this infertility treatment, ma'am?
See, many factors, if we come one by one, the COVID has damaged every family financially and health wise. So definitely the IVF treatments have been affected. Psychological factors are involved here. And next thing is regarding the male factors. The male infertility has been increasing. Same thing again. And then the females are, I can say, not much difference in IVF techniques or IVF procedures. But definitely the male factor is being affected and financial issues have come post-COVID.
Okay, ma'am. Ma'am, we have one more question, ma'am. Recurrent IVF failure. What next, ma'am? What should be the next stage?
This is the most difficult thing for the couple.
Yes, ma'am.
See, what I say is we are doing a procedure. Normal definition of fertility in a couple is we wait for 1 year after the marriage, right? So what I say is you have to counsel the patients. You cannot expect or you cannot tell them that, or they should not take it for granted that every IVF cycle is a success. It is not possible. When God's IVF cycle is a duration of 1 year, how can a man's IVF cycle be a duration of 1 month? Right? So the counseling here plays a major role. What we counsel the patients is 3 months is one IVF cycle. And usually it takes 3 to 4 cycles for an IVF cycle to be succeeding, for her to be pregnant. Next, now we are talking about the pregnancy. And the next thing is a live baby in their hand. Many factors are involved in it. So the counseling plays a very important role first, so that they understand that you take the egg, you fertilize, and you're putting a baby in her womb and she's going to be bomb pregnant. That is not true. So the two IVF cycle failure should be imbibed in their in their brains, in their family. Right? That's a very important point. See, IUI cycle, IVF cycle, you cannot say that you're going to succeed in 4 cycles, 3 cycles, 2 cycles. That is the first thing which has to be imbibed in a couple, in a family who are coming from IVF. Next, from the doctor's side. See, each IVF cycle is very precious and involves money, emotional factors from the couple side. Right? So the first, you have to be 100% accurate when you're doing an IVF cycle. The next, you have a failure of the IVF cycle. I don't think you should wait for the second IVF cycle also. First failure, you're going for ICSI. 2 ICSI failures, you're going for DNA fragmentation, PGF, donor, embryos. Any other doubts?
Ma'am, there is no other questions in the chat box, ma'am. Ma'am, if you allow us, then we can end the webinar for today.
Yeah.
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 So thank you, ma'am. Thank you very much for spending your valuable time with us today, ma'am. We are looking for many more webinars with interesting topics with you, ma'am. Please do support us and make our team also to be supported, ma'am. Thank you, ma'am. Thank you very much, ma'am.
Thank you. Okay.
Thank you. I'm ending the webinar.
Yeah.
మేడం గారు థ్యాంక్ యూ మేడం గారు.
థ్యాంక్స్ అమ్మా. ఈ టాపిక్ కొంచెం డిఫికల్ట్ కదా, సో ఎక్కువ మంది ఫాలో అయ్యారో లేదో. హలో.